Colorectal cancer treatment has undergone a paradigm shift. We no longer see this disease as a singular anatomic tumor, but rather a set of disease subgroups. Largely because of a better understanding of cancer biology and the introduction and integration of molecular biomarkers, we are beginning to direct treatments towards the right tumor targets in the right patients.
The field of molecular profiling is continually evolving, and new biomarkers are constantly being discovered that have investigational, therapeutic, and prognostic implication. Hence, it is vital that the treating oncologist should know which biomarkers to assess, when in the treatment course to test for them, and how the test is to be done. Keeping this in mind, let's move on to our next session, tumor biology and its importance in our population.
Ladies and gentlemen, now to carry out our second session, I am pleased to invite on stage Dr. Sidra Masoom. She is a senior registrar of surgery at Dow University of Health Sciences, Karachi, and a consultant general surgeon at secondary hospitals. She completed her MBBS in 2015 and cleared FCPS in 2021. She has worked as a surgeon in Sindh government hospitals. She is interested in minimally invasive surgery and upper GI surgery. Ma'am, please, could you please come on the stage and lead this session?
Assalamu alaikum and a very good morning to all of you. Now I'll call the panel of experts on the stage. Professor Fawad Ali Musa. He completed his fellowship in surgery from Ireland. He is the ex-chairperson of Department of Surgery at Dow University of Health Sciences and ex-HUD of Surgical Unit 1 at Civil Hospital, Karachi. Currently, he is a faculty member of surgery at College of Physicians and Surgeons, Pakistan, and a senior examiner of FCPS at CPSP. He is also a consultant journal and laparoscopic surgeon at Dr. Ziauddin Hospital, Clifton, and Kutiana Memon Hospital, Kharadar. Sir, please welcome. Our second expert today is Professor Farhad Jaleel. Professor Farhad Jaleel is a fellow of College of Physicians and Surgeons, Pakistan, and Royal College of Surgeons. Recently, she is heading Surgical Unit 3 at Dow Medical College, Civil Hospital. She has a special interest in breast oncological and reconstructive surgery. She has 21 national and international publications. Our third panelist for today is Dr. Noor Muhammad Somro. He did his MBBS from Dow Medical College in 1990. He completed his MCPS in oncology in 2001, in which he received gold medal from CPSP. He did his master's in sociology in 1999 from Shah Latif University. He was given Appreciation Award by Government of Sindh for establishing Cancer Care Ward in Civil Hospital in 2006. He also has the honor of being Medical Superintendent of Civil Hospital Karachi for a period of 1.5 years. So, our final panelist for today is Dr. Ahmed Nazim Abbasi. He is the Professor of Radiation Oncology at Aga Khan University, Karachi. He is also the Chairman Radiation Oncology Transdisciplinary Education Programs and Secretary General Radiation Oncology Society, Pakistan. His international academic involvement include exchange program with Italy. He is a trainer in UNDP IAEA program. He is a secretary working group Astro. He is also working in experience program with Turkey in Parton project. He is a member of Canada-Pakistan Research Council and observer examiner at Royal College of Ireland and Turkish Board. He has delivered multiple talks on healthcare, service development and leadership skills in international and national conferences. He has published 135 papers and 17 books internationally and nationally. Sir, welcome. Now I'll invite our first speaker for today, Dr. Najib Nematullah. He did his MBBS from Dow Medical College in 1989. He is a diplomat of American Board of Internal Medicine, Medical Oncology, and Hematology. Currently, he is working as a consultant hematologist and oncologist at Sindh Institute of Urology and Transplantation and Shaukat Khanum Memorial Cancer Hospital and Research Center. He is also an honorary faculty member at Dow University of Health Sciences. Sir.
Thank you very much, Dr. Sidra, and Bismillahirrahmanirrahim. I would like to thank the organizers for inviting me and giving me opportunity to discuss this important topic. So topic for today is the role of adjuvant chemotherapy in stage 2 colon cancer. As you all know that it's a third most common tumor globally, colorectal cancer, and it accounts for almost 600,000 deaths in the world annually. According to GloboCan 2020, colorectal cancer is 5th leading cause of cancer in Pakistan. We have different cancer registries in Pakistan, like in Aga Khan and in Shaukat Khanum, but we don't have a proper whole Pakistan registry. So I don't know how much this data is verifiable. Okay, I'd like to start with a case and then base my talk on this case. This is a typical stage 2 colon cancer case, 55-year-old man with no comorbids, present with a bleeding rectum, with no family history of colon cancer. He underwent colonoscopy, found to have ascending colon mass, and the biopsy showed adenocarcinoma. And the staging workup was negative for metastasis. Pre-op CA was normal. One, here I want to show you just a couple of things. One is, it's a pointer knee. Anyhow, the two important things is, one is we need CT. One important thing is that we need to do a CT scan, chest, abdomen, pelvis for staging, and there is no role of PET CT scan. PET scan we only do in those patients for staging in which there is any abnormality on CT scan which is questionable, and we want to further investigate that in order to decide whether this is related to malignancy or not, and if the patient has a curative modality available. If the patient has no curative modality available, then there is no point in doing a PET scan and looking for the disease. So PET is not a necessary test in staging of the colorectal cancer. Okay, the patient underwent right hemicolectomy, and we used to see these kinds of report that right hemicolectomy specimen infiltrating adenocarcinoma, invading through the muscularis mucosa into the serosa, proximal and distal margins negative for tumor, circumferential margin 0.2 centimeter, and none of the lymph nodes show tumor metastasis. This report shows that the patient has stage 2 colon cancer, but there are a lot of things which are missing. What things we are missing? It's T3 and 0, no doubt, but for T3, there is T3, T4A. Stage 3 is T3, T4A, and T4B. Means if the tumor invades beyond muscularis mucosa of colon, then it's T3. And if it's involving the visceral peritoneum or invading the adjacent organ, it's T4. So these three tumors comprises of stage 2 colon cancer if the lymph nodes are negative. So the missing points are in examination, initial examination pre-op, in CT scan pre-op, which was done pre-op, and per-operative signs of bowel obstruction or perforation. So these three things we need to know for decision of adjuvant chemotherapy. So we need a good CT scan and operative notes also to find out what were the operative findings of the tumor in order to decide whether the patient needs chemotherapy or not. In histopathology report, we need tumor grade, perinodal and lymphovascular invasion, margin clearance, perforation, and number of nodes involved. So a good pathology report is like that it has all the information needed to decide about the further treatment in adjuvant setting. So if you look at the treatment of colon cancer, for stage 1, it's very easy that there's no need for any adjuvant treatment and the patient can be put on surveillance. The only treatment is surgery. For stage 3, it's chemotherapy, surgery followed by chemotherapy. There's no two questions. The problem is in stage 2, where the treatment is surgery with or without chemotherapy. So we have to decide which patients need chemotherapy. If you look at the NCCN guidelines for adjuvant treatment, more than half of the page of adjuvant treatment is for stage 2. There's only one line for stage 1 and 2 lines for stage 3. In stage 2, you should know whether the patient has microsatellite instability or not, whether the patient has high-risk features or not. All these things will help us in deciding the adjuvant treatment. And on that basis, we divide the patient into a good risk and a poor risk. And if the patient has good risk, they have good survival, and the patient have poor risk, then patient have poor prognosis, and these are the patients who need adjuvant treatment. So this is the population of patients who have stage 2 colon cancer, and some of them need treatment with therapy, and some of them need wait and watch because they have a good prognosis. So the goal for today is to find out whether we can differentiate these patients. So first of all, we do some basic work like age of the patient. The patient is more than 70 years of age, or if the patient has a poor performance status, usually we don't give adjuvant chemotherapy. If the patient has comorbidities, especially coronary artery disease, then the backbone of our treatment is fluoropyridines or 5-FU based. And 5-FU is notorious to cause coronary artery disease, so means that can cause increased ischemia. So we have to rule out any history of coronary artery disease. Then patient life expectancy, potential risk of complications, because all these chemotherapies are not benign, they have a lot of complications, and there's a chance of 0.5 to 1% morbidity or mortality actually in patients with colon cancer if we treat them with chemotherapy. Okay, this is MSI or DMMR status. MSI is basically in HNPCC or Lynch syndrome. There is a mutation in the group of genes that are called MMR gene, and that comprises of MSH2, MLH1, PMS2, and MSH6. These are the 4 genes, and sometimes they take EPCAM. If there is any mutation or loss of the one or more of these genes, then we say that these patients have microsatellite instability. And these patients are more prone to develop cancer, and this is checked by either PCR or ISC. So 20% of the patients with stage 2 cancer have microsatellite instability or deficient mismatch repair status. Usually they are young with higher T stage and lower nodal stage. Right-sided tumors are more common to have this abnormality, and these tumors are usually high-grade tumors. And it's a most reliable prognostic marker in deciding the treatment or management of stage 2 disease. So in untreated stage 2 disease with microsatellite instability, they have an excellent prognosis compared with those who have stable disease, stable or proficient mismatch repair status. Stage 2A, which means T3 disease, have a prognosis of survival of more than 95%, And actually, they can have a harmful effect if they are treated with 5-FU-based chemotherapy. And for patients with MMR, deficient MMR, stage 2B or 3C disease, we have to give oxaliplatin with 5-FU because only 5-FU will be detrimental. So sometime with the stage 3 disease, we give only capecitabine or 5-FU, but in stage 2 disease with high MSI, we usually give oxaliplatin with this 5-FU. Okay. Other major prognostic factors are inadequate nodal sampling. This is one of the most important prognostic factor. 12 nodes are very important. You have to take out 12 or more nodes, and that depends on the surgeon. If the patient has less than 12 nodes, then the chances of having node positivity will increase depending on the number of nodes. So if you ask surgeon why the nodes are low, then they will say that's a problem with the histopathologists, and histopathologists they can't see any more lymph nodes. So a good surgery and a good histopathology report will give us a proper nodal status, which will give us proper prognostic value. The second thing is T4 disease. Actually, stage 2B and 2C, that means T4 disease, T4N0, has a less overall survival as compared to stage 3A disease, means T3N1 disease. So even that stage is 3, but the prognosis is better as compared to T4 disease. The other high-risk factors are lymphoproliferative invasion, perineal invasion, clinical obstruction, bowel perforation, poorly differentiated histology, and positive margins after surgery. There are few molecular profile of predictive variables like oncotype DX colon. Those who do breast surgery, they know that oncotype DX in breast is very important in those patients who have ERPR positive, HER2 negative disease, and we decide in node positive patients whether we have a low risk disease or a high risk disease, and we give chemotherapy according to that. So same thing in colon cancer, oncotype DX colon or coloprint or CALX. These are the molecular profile, but they are still in experiment, and we probably in the future we might be able to use these tests to decide whether the patient needs chemotherapy or not. Okay, circulating tumor DNA basically is the DNA released by the tumor cells in the circulation after surgery. And the lower the circulating tumor DNA, the lesser is the chance of developing colon cancer. So on the basis of circulating tumor DNA amount, we can decide whether the patient is a low risk or high risk disease. And again, same is with the immunoscore. Quantities of infiltration of CD3 and CD8 T cells in the tumor can tell us the immune system of the body, the immune reaction from the body on the tumor cells. And if the patient has good immune system, good immune reaction, then the chances of developing the cancer, means recurrence of the cancer, are low. So these two tests, immunoscore and ctDNA, these are probably the future tests to decide whether the patient has a low risk disease or a high risk disease. These are the relevant studies which were done in stage 2 colon cancer to decide about chemotherapy. And if you look at these studies, they all include stage 2 and stage 3 disease. So we don't have a specific data of stage 2 disease. We decide on the basis of stage 3 disease whether to give treatment on stage 2 or not. So if you look at the algorithm, basically in stage 2 colon cancer, the patient is fit for chemotherapy. You see whether the patient has T3 or T4 disease, or whether it's a MMR deficient or not. And if the patient has microsatellite stable disease, then we give chemotherapy. If the patient has microsatellite unstable disease, Then we give chemotherapy in T4 disease, not in T3 disease, especially if the patient has high risk factors. In surveillance, we do CEA every 3 to 6 months for 5 years, CT scan yearly for 3 to 5 years, and colonoscopy after 1 year, 3 years, and every 5 years thereafter. So in summary, the role of adjuvant chemotherapy remains controversial because of the heterogeneous nature of the disease. Not all patients with stage 2 tumor should receive adjuvant chemotherapy. The identification of prognostic factor might help in distinguishing patients with high-risk disease and we can give chemotherapy. Effect to develop molecular profile of predictive variables that could potentially guide adjuvant therapy decision in stage 2 disease have not proved useful clinically yet. The role of adjuvant therapy in stage 2 colon cancer should involve risk stratification and shared decision making with the patient. And the most important thing is all patients of cancer should be discussed in a multidisciplinary tumor board meeting, and that is very helpful for the patient. Thank you very much.
Questions end में रख लेते हैं.
Okay. Thank you.
For doing everything in time, mashallah, as always.
Our second speaker for this session is Dr. Naila Kiani. Professor Kiani is a medical graduate of Fatima Jinnah Medical University, Lahore. She did her residency training in USA and is board certified in anatomic and clinical pathology. She is a fellow of College of American Pathologists and Royal College of Pathologists, UK. Recently, she was appointed senior examiner in histopathology by Royal College. She is currently a dean of the Faculty of Histopathology at College of Physicians and Surgeons, Pakistan. Her special areas of interest in clinical care are breast and gynecological pathology, and other areas of interest are postgraduate medical education and quality improvement processes. She has held close to 30 national and international workshops and given 50 invited lectures in her area of interest. She has over 150 indexed publications to her credit. Professor Kiani, please.
Thank you, Dr. Sidra. I begin in the name of Allah, the most benevolent and merciful. So, can we have the first slide, please? So I will be talking about biomarkers in colorectal carcinomas, and this is something that is a lot of future to promise, and I'm so glad that Dr. Najib Nematullah has touched upon some of the themes that I will be talking about, like microsatellite instability, circulating DNA, and the gene profiling tests. So that gives me a good platform to reflect further on them. So some slides mere paas hai. I have to control. I have to make sure I press the right button. Yeah. So globally, this is the second common, the colorectal cancers are the second common malignancy, and third most in males and third most common in female. In the US also, it is the third most common malignancy. In Pakistan, as Dr. Najib Nematullah mentioned, there are many cancer registries, but there is a recent one that has been formed by a number of leading hospitals in Karachi along with NIH, Islamabad. And according to their data, it is the third more commonest malignancy in males and sixth most common in females. Predominantly, this is a disease that occurs sporadically, and some percentage is hereditary, which is about 10 syndrome, including the Lynch syndrome profile. What are biomarkers? These are substances that are present in our body, either as in a biological or a chemical form, that can be used as a markers to look at a characteristic of a tumor. They are currently, most of the used is being targeted towards development of personalized treatment, because the genomic profile of each tumor is considered to be unique to a given patient, and that the aim is to actually target that particular profile and manage the patient accordingly. They can be classified into diagnostic, prognostic, predictive, pharmacodynamic, etc., recurrence markers. But what is most important are the two categories, which is the prognostic biomarker or a predictive biomarker. So prognostic biomarker is something that tells you about the patient's overall cancer outcome, and I would give you the example of ER or estrogen receptors in breast, which is also a prognostic marker and also predictive. So how do you apply that knowledge? Well, if a patient is ER positive, is likely to do better than some of the other groups which are ER negative. Also, if patients, you give them to this group, you give them anti-estrogen therapy, so then they have a better outcome. So this is how that information is well established in breast. But at colon, we are in a struggle to develop something as robust as a ERPR. So how do these biomarker works? Very briefly, I will take you over this concepts of how these, there are three main mechanisms through which they work. One, and the larger group which is responsible for colonic carcinomas is the chromosomal instability group, which is also called CIN and responsible for about 85% or so. Then we have the microinstability group, which is MSI high, and it's about 15% or so. And then there is another, which is in which the cancer is promoted through methylation. And in addition to this, these mechanisms, there are other things that determine the prognosis in a patient, which include the TNM stage, the location, and the histological subtype. This is the characteristic, if you look at the upper half of the screen, the characteristic profile of developing colorectal carcinomas by a model that is well known, in which there is normal tissue, there is involvement of the genes, which are the tumor suppressor genes, and including including P53, APC, and other genes, and then they may go on to develop a tumor which is going to be, which may have microsatellite instability or may not have microsatellite instability, depending how the genetic profile or genomic profile evolves. So these are the two types that you can have, and then there is the third type, which is the tumor which will have the methylation defect. If the methylation defect involves the MSI, then it will be an MSI group, and if it involves the tumor suppressor gene, then it will be the MSI stable group. So the most common, as I said, is the CIN group, in which you have chromosomal instability, and this is manifested by loss of alteration in certain chromosomes or mutation, and the particular the tumor oncogenes that are involved are BRAF, KRAS, T53, and APC. At the end, and the pathways that are involved are PK and WTN. Why is it important to know? Because some of the drugs that we have now are actually acting on these pathways. KRAS is one of the most common culprits in this, and KRAS is involved in the division and in cell division, and it is a marker of poor survival and increased tumor aggressiveness as well as metastasis. And then also it may give us key to the presence of decreased response or resistance to certain drugs. So epidermal growth factor, as you can see on the cartoon on the right-hand side, can be seen on the surface. And then there are two pathways that lead through this, the Wnt and the MAPK pathway. And you can notice at the very periphery of the right-hand side of the slide, there is a heading saying RAS, which is KRAS, and underneath is RAF, which is BRF. And these are the pathways that are involved in further cell growth and division. So once these are affected, these are triggered on, there is increased cell survival, there is a loss of apoptosis, angiogenesis, and metastasis can take place. So why is it important to know the pathways? Because they can, when you give a medicine, at times these pathways will block some of the EGRF activity, but will not affect the KRAS and the BRAF, and therefore it is important to know what is the status of these patients. So in microsatellite stability, this is something that happens during DNA replication, and because we have in our bodies MMR proteins, which are the mismatch repair proteins, they protect us from microsatellite instability. And this is a cartoon on the right-hand side showing you how various functions of this are performed. But once there is a defect in the mismatch repair system, we lead to unstable proteins, and these then proteins will lead to damage. So there is a group, which there are 4 of them, MSI1 and PMS2 and MSH2 and MSH6. Now they occur in pairs. So MS1 and PMS3 is a pair, and the other one is MSH2 and MSH6. Now, if the MSH1 is affected, usually there is loss of both, but if 1 and 2 are affected in a pair, then the other partner becomes non-functional. In our genomes, we have more than a million microsatellite instability checkpoints, but there are 5 that have been picked up by NIH, Bethesda, Maryland, USA, to be tested, to be used as a test. So these are some of the methods in which MSI can be checked, and what I want to point out that the gold standard is, of course, PCR, but what is routinely available across Pakistan in many leading laboratories is through the immunohistochemical stains, and that's a very reliable method, and you can see the reliability is as high as 95%, and I would encourage you to use that service because that's readily available and it is not very expensive. Then we have the third system through which tumor can occur, and that's the methylation pattern. And this methylation pattern can either affect the tumor suppressor genes or the MSH1 system. So this is methylation and occurs through the cysteine guanine phosphate islands that are present in our genomic profile. This is just to quickly show you that most of the tumors occur through a mechanism involving the KRAS, and a minority is through MSI. But where it is the highest areas involved are the cecum, rectum, and part of the ascending colon. This is some of the clinical and biomarkers that are actually, this is what is currently known to or is advised to use, and that's microstability, MSI profile, the KRAS or the NRAS and BRAF mutation. This is what is required that should be tested in a given patient. And you can see why it is important because, let me see if the pointer works on this side of the screen, because you can, what is happening, what is new in terms of MSI is the fact that you can use now PDL1 and PD1 immunotherapy in these patients, and there's strong data now to use this in this group. So that's a great ray of hope that has emerged recently. I won't go through this detail, but it's just there to show you what else is being there, and ctDNA, as Dr. Najibullah mentioned, then, and how you can use targeted therapy in that regard. Similarly, there are some for some others, but mostly you see when there are a lot of red checks, and that when those red checks are present, it tells you that the treatment won't be beneficial. So there's a lot happening in terms of trials and what is new emerging, data that is emerging, but this is yet to be proven in clinical. These are some of the gene signatures for colorectal carcinomas. These kits, they look at various genes in a larger form, 18, 16, whatever, but none of them is yet FDA approved. So this is still work in progress, but with a great promise. I would just want to, being a histopathologist, wanted to flash you that there are many other things which are helpful in histopathology, and it is not only the genomics that are going to lead us in this. So genomics actually adds upon the histological knowledge that we have. So that will still be there, and then this will be additional information. So many things like lymphovascular invasion, tumor infiltrating lymphocytes, and microvascular density, and many others which I have not directly reading through, will help us determine the future of this profile. So this is a guideline as to what to do in patients who have metastatic disease versus non-metastatic disease. And then this is just a summary of what I've said, the three types and how do you manage these various types. There's this, the CIN group, which is the chromosomal instability, the MSH group, and then the methylation group. And this is what is suggested to be used in this form. So when you have a patient who has, you should do molecular screening. Molecular screening is now available in the form of NGS, at least in our institution. I know it is expensive, but it is worth it. You are, after all, trying to save a human life or have a better quality of life. So you can either do molecular studies for prognosis, or you can have biomarkers for predictive, or you can exclude Lynch syndrome, etc. Then liquid biopsy, which is actually the circulating DNA, can be used. And this is something which still has to prove its worth, but very much on the horizon. So in conclusion, I would like to say that mutational testing of specific genes for EGFR is been well known to have as a targeted treatment. Mutations in some have prognostic value like BRAF, KRAS, and NRAS. And BRAF has associated with poor outcomes, and MMR protein dysfunction or deviation is very helpful, because now we have a chance to treat this group with immunotherapy. So thank you for your attention.
Thank you, Dr. Naila. Now I'll invite our third speaker for this session, Dr. Sehrish Abrar. Dr. Sehrish Abrar is a consultant radiation oncologist at Aga Khan University, Karachi. She completed her training in radiation oncology at Aga Khan University in 2018. Her clinical areas of expertise include gynae, breast, gastrointestinal, and skin cancers. Dr. Abrar has been actively involved in education and teaching to residents and radiation technologists at all levels. Her research interest includes gynae oncology, re-irradiation outcomes, radiomics, and clinical audits. Dr. Abrar is coordinating the RO Research Forum, and she has published manuscripts in national and international journals. She is a part of Irish, Turkish, Canadian, and Italian professional development exchange programs. She is the chairperson of Rectal Cancer Study Group in Pakistan. In addition to these, Dr. Abrar has been involved in developing departmental treatment protocols for pelvic malignancies, leading and coordinating site-specific multidisciplinary teams inside and outside Pakistan. Dr. Abrar, please.
Assalamu alaikum, everyone. I'm Dr. Sehrish Abrar. I'm a consultant radiation oncologist in Aga Khan University Hospital. Can you please put up the slides? So today I'll be talking about the organ preservation in the rectal cancers, when, why, and how. A very nice discussion has been made in the previous session. I'll be touching upon many of the similar points in my presentation. So the outlines of my presentation are the organ preservation in the rectal cancer, when, why, and how we can offer the organ preservation. So first of all, I would like to define the organ preservation. The organ preservation is defined as when the rectum is intact after the treatment and the surgery in the form of TME is not being done, and if the patient have the locoregional regrowth that is salvageable by the local excision. When we can offer the organ preservation. So we all know that there are many studies where the neoadjuvant concurrent chemoradiation therapy is being done in the locally advanced rectal cancer patients, and we see the pathological complete response in more than 15% of the patients, especially in the locally advanced rectal cancer. And this number is more in cases of the early tumors. It is more than 40% when we are dealing with the early tumors. So this has been taken from the Astro Clinical Practice Guidelines. In the Astro Clinical Practice Guidelines, they mention that that the appropriate indication for consideration of the non-operative management or the local excision approach after the definitive or the preoperative chemoradiation therapy are, it is being done after the multidisciplinary team discussion, and it is only offered to the patient who don't want TME or who would have a permanent colostomy or inadequate bowel continence after the TME. And very, very important point is that that the patients agree to the stringent follow-up. Without the agreement of the patient having coming on the stringent follow-up, we cannot offer the organ preservation. Now, why we may offer the organ preservation? So this is actually the surgical series, and it's a long-term outcome in the patient with pathological complete response after the chemoradiation for rectal cancer. So in this retrospective surgical series, more than 3,000 patients were included, and they all had the pre-op concurrent chemoradiation therapy followed by the surgery. So in this surgical series, they find out that 15% of the patient had the pathological complete response, and in this analysis, they try to see the 5-year disease-free survival. And here you can see, sorry. I'm going forward. Okay, so here you can see that those patients who had the complete response of the treatment, they had the better local control as well as the distant control. They had the better overall survival and the disease-free survival as compared to the patients who were non-responders. Now again, this is a surgical series, and in the surgical series, a correlation is trying to made between the YPT stage and the lymph nodes in the mesorectum in the patients who had the concurrent chemoradiation therapy followed by the surgery. So 20% of the patients had the pathological complete response in the series, and here you can see that those patients who had the complete response after the neoadjuvant treatment, PT0, they had the chances of the lymph nodes in the mesorectum is very less. It is just 1.8%. And if it is PT1, the chances of the lymph node in the mesorectum is 6.3%. Now I'll discuss that how we can offer the organ preservation. Now, the organ preservation can be offered to those patients who achieve complete response or the near complete response after the neoadjuvant concurrent chemoradiation therapy. So organ preservation can be offered in the two forms, either a non-operative management, which is the watch and wait approach, and the other one is the local excision. In the local excision, it's in the early tumor after the chemoradiation therapy, the transanal local excision is done, and only the mucosal, submucosal, and a part of the mesorectum is being removed with 1 centimeter clear margin. So this is the GRICAR-2 study. In the GRICAR-2 study, they included the lower rectal cancer patients who have the disease within 8 centimeter from the anal verge. The disease of the circumference was 4 centimeter or the less, and they included only the clinical T2, T3, N0, and 1 patients. And all the patients received the chemoradiation therapy, 50 gray radiation was given, and then the response was evaluated. Then the patient was stratified either the good responders or the poor responders. Those who were considered the good responders, they have the complete or the near complete response. They were being offered the local excision. After the local excision, if the patient have the YPT0 T1 disease, they were offered the follow-up for 5 years. And those patients who had the YPT2 or T3 disease, they had the completion TME. Here is the number of the total statistics of this study. That total 145 patients were included, and the 74 patients were being offered the local excision. In the 73% patients who had the local excision, 39 patients had the good response. They had the YPT0 disease, YPT0T1 disease, and 34 patients had the YPT2 or the greater disease. So in those patients, the further completion surgery was done. So, so those patients who had the local excision first and then the TME because of the poor response, the total number is 28, and all of these patients had the major morbidity, surgical morbidity issues. So this is actually a negative trial because the patient who received the local excision and the completion TME had the major side effects. After that, the 5-year results of the CRICAR-2 study were published, and in this paper, they discussed the disease-free survival and the overall survival. They talked about that there was no difference in the disease-free survival or overall survival in the patients who were being offered the local excision or the TME. Now I'll talk about the outcomes of the non-operative management. So non-operative management is usually being offered in the locally advanced rectal cancer patients. So we have the retrospective studies and the meta-analysis where this thing has been discussed, and here you can see that in the retrospective and the meta-analysis studies, the rate of the regrowth is 20 to 34%, and the timing of these regrowth is usually 2 to 3 years. So most of the patients had their regrowth in the 2 to 3 years, and almost all of them are salvageable. Now I'll discuss the strategies to improve the complete response. There are different strategies we can follow to increase the clinical complete response. The one way to increase the clinical complete response is the radiation dose escalation. The other way is the chemotherapy intensification. The third method is to increase the timing between the radiation therapy and the surgery. Now, this is the meta-analysis of the 18 studies with more than 1,000 patients were included. And in this meta-analysis, they discussed that more than 60 gray of the radiation were used in the locally advanced rectal cancer patients, and the pathological complete response they achieved was 20%. There was grade 3 toxicity in the 10% of the patients. But in the astroclinical practice guidelines, they categorically mention that the patients who are being offered the non-operative management, better to restrict the radiation dose up to 50 or 54 gray. The reason for this statement was that majority of the series of the non-operative management utilize the radiation doses between 45 to 54 gray, and some studies report the higher rate of clinical complete response with radiation dose escalation, but they are limited in size. And the major reason for not to follow them is that they do not report the long-term patient-reported quality of life outcomes. Regarding the chemotherapy intensification, so this is the timing trial, and in this trial, they included the locally advanced rectal cancer patients. It's a phase 2 study, and they stratified the patients into 4 groups. All of the patients had the neoadjuvant concurrent chemoradiation therapy, and then they want to see the effect of the number of the chemotherapy on the complete response. Like you see in the group 2, they only give 2 cycles of the FOLFOX after neoadjuvant chemoradiation. In group 3, they utilize 4 cycles, and then group 4, they utilize total 6 cycles. And all of the patients had the TME afterward. And here you can see that the pathological complete response was more in the group where the 6 cycles was used. It was 38% as compared to it was a bigger number as compared to the other group. Now, in Rapido study, what the investigators have done, they used the short course regime of radiation. They included the locally advanced rectal cancer patients. They used a short course regime of the radiation and followed by the 6 cycles of the FOLFOX of the K-POX chemotherapy. And all of the patients had the TME. And again, in this study, you can see that the pathological complete response is 28% as compared to the conventional method. It was just 14%. Now, this is the OPERA study. In the OPERA study, it's a phase 2 randomized control trial. In the OPERA study, the patients had the total neoadjuvant chemoradiation therapy. And here you can see that they took the stage 2 and the 3 distal rectal cancer patients, and they were stratified into 2 groups. Either the patients had the consolidation neoadjuvant concurrent chemoradiation or the induction concurrent chemoradiation therapy. In the induction chemoradiation arm, they utilized the chemotherapy first, followed by the concurrent chemoradiation therapy, while in the other group, they utilized the radiation first and then the chemotherapy. And all of the patients had restaged with the DRE, endoscopy, and plus minus biopsy. Of course, the MRI was done. Then the response was evaluated, and those patients who had no clinical response, they were being offered the TME, and the patients who had the complete response, watch and wait approach was utilized. And here you can see that there was no difference in the disease-free survival and the distant metastatic-free survival between both of the groups, but around 50% of the patients in both the groups had the organ preservation in OPERA study. So now I'll talk about the timing. How important is the timing to increase the clinical complete response? So this again is taken from the surgical series, and here you can see that more than 95% of the pathological complete response is usually achieved after the 10 weeks of the interval from the end of the concurrent chemoradiation to the surgery. So the timing is very, very important. If you want to increase the clinical complete response, you may increase the time between the surgery and the neoadjuvant treatment. Now, the very important question that how to determine the clinical complete response. So, to determine the clinical complete response in this paper, they categorically mention that we should use DRE, MRI, and the endoscopy. And all of these 3 modalities combination increases the probability CR prediction up to 98%. Now, an important question that should we do the biopsy of all the patients when we are considering them for watch and wait approach? So the answer is no, because biopsy may give the false negative results. Again, in this is again a surgical series, and in the surgical series, they discuss the correlation between the YPT stage and the residual tumor cells in the different layers of the rectum. And here you can see that in T4 diseases, actually this green line is showing the residual disease in the subserosa, this magenta is showing the residual disease in the muscularis propria. So if the disease is YPT3, T4, the localization of the residual tumors in the mucosa or submucosa is very less. The majority of the residual tumors would be in the muscularis propria or the subserosal layer. The follow-up strategy, a very important question. As we know from the surgical series that the most of the recurrences happens in the first 2 to 3 years. So the follow-up should be very stringent for up to 2 years. Every 3 monthly DRE, endoscopy, and pelvic MRI should be done. And the chest and abdominal CT should be done every 6 to 12 months. And thereafter, the frequency should be less, and it should be done it may be done for 6 monthly. Now, there are many ongoing studies, there are many ongoing phase 2 and phase 3 studies where this watch and wait approach is being investigating. There are Brazilian trial, and there is another trial where the contact brachytherapy is also being used. And in this study, they utilize the brachytherapy to increase the clinical complete response, and they use the 90 gray of radiation dose. They give 90 gray of radiation dose to the patients to achieve the clinical complete response. Now, this slide is about the radiation oncology rectal cancer study group. This group was formed just by our team just to increase the knowledge, or to fill the knowledge gap of our colleagues and to educate ourselves, and to increase our international networking. So the take-home message from my my talk is that we cannot offer this watch and wait approach without having the site-specific tumor board. So site-specific tumor board is necessary if we are offering a watch and wait approach to any of the patient. Thank you.
Thank you, Dr. Abrar. And now the final speaker for this session is Dr. Suresh Kumar. He did his MBBS from Liaquat University of Health Sciences, Jamshoro. He completed his fellowship in pathology in 2018. Currently, he is working as an assistant professor in pathology department in Dow University of Health Sciences. He is also working in collaboration with National Institute of Blood Diseases. Sir, please rise.
Assalamu alaikum. Thank you for organizer for inviting me on this forum. डॉक्टर प्रोफेसर नायला कियानी एंड सर नजीब साहब, उन्होंने मेरी ज़िंदगी आसान कर दी है, आधा तो उन्होंने बता दिया है पहले ही आपको. Today I am talking about, I will focus the new WHO classification of digestive tumors. So I will be focusing mainly on three things, that is updates on the tumor, neuroendocrine neoplasm and the appendiceal tumors, the standardization of the terminology of the appendiceal tumors, and the highlights of the molecular pathology, which professors have already discussed. So the current WHO classification, the neuroendocrine tumors, all neuroendocrine tumors, all neuroendocrine carcinomas are now considered as high-grade tumors. Previously, in the previous WHO classification, the neuroendocrine tumors are classified as neuroendocrine tumors grade 1 and 2, and the grade 3 are considered as carcinoma. But now this grade 3 as a separate entity as grade 3 neuroendocrine tumors. The carcinoma is by definition is high grade tumors. So the all neuroendocrine tumors are high grade tumors. This classification avoids the confusion between the two clinically and molecularly separate entity. So these are the 5 parameters on which we divide neuroendocrine neoplasm into neuroendocrine tumors and carcinomas. So what are these? These are clinical manifestations, the epidemiological data, the histological features, the genetic evidence, and the prognostic differences. The most important is that in the clinical difference, the neuroendocrine carcinoma, they are respond to platinum-based chemotherapy, while the neuroendocrine tumors, they are not. However, the carcinoma have bad prognosis, poor prognosis. Despite that, they respond well to this platinum-based chemotherapy. Other one is, how is neuroendocrine tumors graded? Neuroendocrine tumor is graded on the basis of, graded into 3, grade 1 to 3, on the basis of 2 things, that is proliferative activity, that is assessed by mitosis, and Ki-67 index. So how to grade it? If the mitosis is less than 2, it's for pathological point of view. If the mitosis is less than 2, then it is grade 1. If mitosis is 2 to 20, it is grade 2, and if the mitosis is more than 20, it is grade 3. The Ki67 index, if less than 3, it is grade 1, 3 to 20, grade 2, and more than 20, it is grade 3. But the difficulty arises when their neuroendocrine carcinoma treated by chemotherapy, they have low mitosis index. On this, we assess by not only by mitosis, also by morphology. The neuroendocrine carcinomas have a sheeting pattern and they have necrosis, while neuroendocrine tumors are organoid pattern. They have nested pattern and they rarely have necrosis. So neuroendocrine carcinoma, I have already mentioned, they are not graded, they are highly graded. Poorly differentiated carcinoma, they subdivide into small cell carcinoma and large cell carcinoma on the basis of cell size. So in this photomicrograph, you can appreciate small bowel mucosa with erosions, and the submucosa and muscularis shows the tumor cells arranged in the nested and organoid pattern and cards. On this photomicrograph, here you can appreciate the tumor cells surrounded by fibrosis. On higher magnifications, the tumor cells have clumped salt and pepper chromatin with scant cytoplasm. In this photomicrograph, we can appreciate the tumor cell is a sheeting. अब इसमें pattern नहीं रहा. There is no organoid pattern. Sheets हो गई हैं. Tumor cells is sheets. These are the sheets, and this is the necrosis, and there is a crushing artifacts. So this is the picture of small cell carcinoma. Here these tumor cells have large size. There is a brisk mitosis, and this cell size is large with tumor cells with prominent nucleoli. Most of the time, small cell carcinoma have no prominent nucleoli. But if the cells are large size, they have prominent nucleoli with brisk mitosis. So this is the large cell neuroendocrine carcinoma. So now then another new thing that is in WHO is mixed neuroendocrine neoplasm. To qualify mixed neuroendocrine neoplasm, the tumor should have neuroendocrine as well as non-neuroendocrine tumors, both morphologically as well as immunohistochemically proven. To call mixed endocrine neoplasm, each component, either of component should be more than or equal to 30%. And each component graded separately. Like if the patient have adenocarcinoma, they separately graded. If the patient have neuroendocrine carcinoma or tumor, they are separately graded. Why we grade this? Because if the tumor have neuroendocrine component, if it is only a small type, if in a focus only, if it is 30%, then they respond to platinum-based chemotherapy. So this should be mentioned in the report. If this tumor not qualify as more than 30%, but we should report that adenocarcinoma with neuroendocrine tumor percent, जितना percent वो आ रहा है. So previously they are called mixed adenoneuroendocrine carcinoma, manic. Mixed adenoneuroendocrine carcinoma, now they are called mixed neuroendocrine tumors, carcinomas. So here we can appreciate the gastric mucosa with few glands are infiltrating, and they are surrounded by low-grade neuroendocrine tumors. In higher magnification, you can appreciate the glands with occasional, there is mitosis, and there is the tumor cells with eosinophilic cytoplasm and hypochromatic nuclei. So now come to the genomic difference. What is the genomic difference? The genomic difference is that neuroendocrine tumor, the neuroendocrine tumors have mutations like MAN1 gene, the death domain associated protein DAX, and the ATRX gene. While neuroendocrine carcinoma have other pathway like P53 and RB genes. And they have less commonly, these genes are less commonly observed in the neuroendocrine carcinoma. So both have different pathways. So, to concluding this, that neuroendocrine carcinoma are more aggressive, they are poorly differentiated, they have more than 55% characteristic index, they have P53 mutations, and they have seldom low-grade components. Like neuroendocrine tumors may have low-grade component like grade 1, grade 2, they may have neuroendocrine tumors. But neuroendocrine carcinoma rarely have low-grade components. If they present with like mixed tumors, they may have precursor lesions like squamous dysplasia or colonic adenomas. So they form mixed adenoneuroendocrine tumors. So now come to the tumors of the appendix. The tumor of the appendix are broadly categorized into 4 categories. These are the sessile serrated lesions or polyps, the mucinous neoplasms, the adenocarcinoma, and the neuroendocrine neoplasm. So sessile serrated, previously they are called sessile serrated adenoma. Now they are called lesions. Why? Because all these are not polypoidal in nature. All the lesions are not in the adenomas. Some are flat lesion, some are only flat, they have a dysplasia. So we also call them as adenoma. So before, to avoid the confusion, we label as sessile serrated lesion. If they come to be polypoidal, we say this is polypoidal polyps, hyperplastic polyp. If the hyperplastic polyp have genetic mutations, then we say that is adenoma. So we prefer these lesions. So these sessile serrated have mainly KRAS and BRAF mutations. If they polyps, previously we called as hyperplastic polyp, but these mutations if present, though this is now a neoplastic. And few sessile serrated lesions without dysplasia, they have distorted crypts. The crypts are deeply present into the, and crypt dilatation is present. Sessile serrated with dysplasia. With dysplasia, the serrated architecture is maintained. Serrations is maintained, but there is dysplasia. This dysplasia of traditional type, this dysplasia may be of conventional type. So this, in this photomicrograph, we can appreciate the sessile serrated lesion. In this high power view, we can appreciate the serrations at the apex, and there is intact musculus mucosae. Now to come to the appendiceal mucinous neoplasm. Appendiceal mucinous neoplasm are again categorized mainly into 3 things. One is low grade appendiceal mucinous neoplasm, other is high grade appendiceal mucinous neoplasm, and third one is mucinous carcinoma. Low grade appendiceal mucinous neoplasm is that if the dysplasia of low grade and there is no invasion, these are called low grade appendiceal. If the dysplasia of high grade, no invasion, called high grade. If there is an infiltrative invasion with desmoplastic response, so this is called mucinous carcinoma. So the term cystadenoma is now replaced by low grade appendiceal mucinous neoplasm. Now if the patient have these appendiceal neoplasm, low grade or high grade, if they present extra appendiceal spread, previously we called them as adenocarcinoma, but now we term used as disseminated to the peritoneal cavity or peritoneal metastasis. Previously we called as adenocarcinomas. So the important thing is that if mucinous tumor confined to the appendix, the treatment is only appendectomy. So this should be mentioned in the report that tumor is confined to the mucosa, to the muscularis or serosa, but there is no extra appendiceal spread. So this is only treated by appendectomy. This phytomicrograph shows low grade appendiceal mucinous neoplasm in which the mucosa is directly, they have no muscularis mucosae and they are directly lying onto the muscularis propria. सब म्यूकोजा और लेमिना प्रोप्रिया इसमें नहीं होता. This is the difference between low-grade appendicitis neoplasm and previously we discussed. The mucinous lesions confined to the appendix, they are treated by simple appendectomy. So, due to the not presence of the muscularis layer, the lesions is TNM classification is says that they have T1, T2 are eliminated, and they have TIS, T3 and T4. TIS, the lesion confined to the like lemon. Lemon is TIS. Low-grade appendicitis is TIS. If the lesion is present into the subserosa or serosa, they are called as T3 and T4 respectively. So, close follow-up recommended of the patient with these tumors, and hyperthermic intraperitoneal chemotherapy is for the extraappendiceal mucinous tumors. This is the last one, the appendiceal goblet cell adenocarcinoma. The adenocarcinoma, previously they are called carcinoids, goblet cell carcinoids. Why we call the goblet cell adenoma? Because they have mucin secreting cells. The majority of them are mucin secreting cells. That's why we call as goblet cell carcinoma. They have indolent cause, they have depend on the grade of the tumor. So, this is the cohesive goblet-like cells present in the muscularis layers and the serosa, subserosa. To call goblet cell carcinoid, low-grade component should be present, because if the tumor total tumor is high grade, then it is very difficult to distinguish from signating cell adenocarcinoma. So, prognosis of the lower grade is better than the intermediate and high grade. So, now this is the last thing to discuss, but on the fortunately the Professor Dr. Naila Kani or Professor Najib Saab have discussed on this molecular advances. So, I just go through the slides. Okay, these have the already madam mentioned that these have MMR mismatch repair gene have 4 proteins basically, that is MLH1, MSH2 and MSH6 and PMS2. They work together. If they are present, this is the Lynch syndrome. If there is a hypermethylation, if only MLH1 promoter methylation, though they may be they case sporadically, the case will be present. So, इसकी ज़रूरत क्यों पड़ी? इसकी ज़रूरत इसलिए पड़ रही है कि to not only diagnose this, but Professor Saab already said that to give the neoadjuvant chemotherapy in the stage 2, especially stage 2 cancers. So, these are they don't respond to from this 5-fluorouracil therapy. So, PDL1, it is important, very important. PDL1 is inhibitor used in MSI cancers. बस ये अब लास्ट दो हैं. So, the recent studies say that esophageal adenocarcinoma with HER2 new overexpression, they have survival better with neoadjuvant chemoradiation therapy. Gastric carcinoma में अब EBV कराना ज़रूरी है, because they have better survival and prognosis. KRAS and NRAS, they mainly in the colorectal carcinomas. They are resistant to EGFR therapy. P16, we routinely do in the cervical cancers or oropharynx carcinomas. Now, this this study says that the P16 may be done in these anal lesions of squamous origin. So, to summarize that, the G3 is a new category. So, this distinguished from neuroendocrine carcinoma, we should distinguish this. And menin, this is mixed neuroendocrine neoplasm, and the goblet cell adenocarcinoma, and the role of molecular pathology in establishing the diagnosis and the predictive markers to prognosis and treatments. These are the references. And thanks to our Professor Dr. Tazeen and Dr. Naseem Saab to support me throughout these presentations, and thank you very much.
Thank you, Dr. Suresh Kumar. Now we will head for the question and answer sessions, please.
I'd like to thank all the respected speakers. It was wonderful listening to all the latest comments and regarding all these biological markers and regarding stage 2 tumor, because that's a controversial thing. As I was reading in the literature, there's still controversy in the stage 2, whether to give chemotherapy or not. And then, as was a good talk with Dr. Sarish about organ preservation and Dr. Suresh about the latest WHO classification on these neuroendocrine. First of all, I think we'll go one by one. We'll just, first of all, we'll invite Dr. Najib Nematullah, please, to come and answer the questions. And we have also some comments to make in there as well. Thank you, Doctor. Any questions from the crowd? Dr. Najib, he had a wonderful talk on role of adjuvant chemotherapy in stage 2 tumor, colorectal tumor. Have any comments or any questions?
There are two school of thoughts. London-based school of thought says wait and watch in stage 2, while the MD Anderson says go for the chemotherapy for the longer benefit of the patient. What I read in my books when I was a postgraduate student, where there is a lymphovascular invasion, you start the chemotherapy whether lymph nodes are positive or not. If the lymph nodes are positive, then the stage will be changed definitely. As you mentioned in your talk, that the T4 is without lymph nodes stage 2. So what you will recommend, will you do in such patients a mutation test, those who have benefited, because they are at a high risk of developing CRC, metastatic colorectal cancer?
Certainly in T4 stage 2 disease, one should consider chemotherapy. The reason to do MSI testing in T4 is that in those patients who have MSI in stable disease, they are not benefited with only 5-FU-based therapy. You have to add oxaliplatin. But in patients who have microsatellite stable disease, you can give only capecitabine or 5-FU, and you don't have to add oxaliplatin.
Dr. Najib, I have one comment and question regarding the same. No wonder that there's still controversy all over the world about whether to give chemotherapy in early one, not the one with the bowel obstruction, or not about talking the T4. So, but like for example, oxaliplatin based, and they have neurological problems, as you know, and they can be short term and they can be long term. What do you have any comments about that, your experience?
Certainly, all chemotherapies have their side effects, and oxaliplatin can cause a severe neuropathy. So in the latest, last year there was a trial done which is called IDEA trial, in which they recommend that instead of giving 6 months of chemotherapy, you can give 3 months of chemotherapy in stage 2 disease.
What about the ones which I just mentioned, like the case who presents with bowel obstruction, perforation, or the one which you mentioned, with T4 ones?
Stage 2 disease
with T4, yeah.
With T4, it has worse prognosis than stage 3 without, with T3 and 1. It all depends on the patient's tolerance of the chemotherapy, and it's better to give 6 months of therapy if they have a poor prognostic factors.
So my question is, this high-risk stage 2 group, including T3, T4 tumors, and particularly T4 tumors and those who present with obstruction and perforation. So is it wise to get MSI and MMR testing, and then after this, and many a time this happens because there is a communication gap between the surgeons and the medical oncologists. So they do the testing and then they say further chemotherapy is not indicated. And to start with, these patients were those who had obstruction or perforation. So is it advisable that, I know that MSI and MMR should be done uniformly on all colorectal specimens. This should be a practice. But again, is it advisable that even if they are not suitable candidate as per testing, we should already give them chemotherapy?
Okay. the issue is that T4 lesion, if you look at the NCCN guidelines, they still say that for T4N0 disease, if the patient has microsatellite instability, you can put them on observation. But most of the studies, they don't follow this. And ASCO guidelines says that if the patient has poor prognostic factors, like T4 disease or lymphovascular invasion and margin positive, they should receive chemotherapy.
So,
the reason for doing MSI testing, the reason for doing MSI testing in stage 2 is to whether to give oxaliplatin or not, number 1. And in stage 4 is to give immunotherapy. In stage 3, there is no need to do MSI testing because no matter what, you have to give chemotherapy.
So another thing. So the problem is that, for all these high-risk stage 2 people, so we know that these guidelines come from the West. They come from a place which has exactly a different tumor biology as compared to what we are experiencing here. A lot of our colorectal cancer is between 30s, 40s, 20s, teens. So all these cases will present with all these horrible T4 lesions, along involving, I respect specimens that, I would take almost half of the hemiabdomen out just to take a splenic flexure tumor out. And again, these lesions would be N0. So I think we are dealing with a different biology. This biology is not what is, we are having the guidelines from the West. We follow those guidelines, but again, our tumor biology is entirely different because, you will have those T4B horrible lesions involving the tail of pancreas, involving the spleen, involving the stomach. You take them out, you take an R0 resection, sample 50 lymph nodes, all negative. So what are we going to do with them?
Yes, in one of my slides, it was stated that the patient who have MSI unstable disease, or they have larger T disease, lower N disease, and high grade disease. These are the 3 features of MSI high tumors. So, and these tumors have good prognosis, but if they have, they are diagnosed in T4 stage, then I think they should receive oxaliplatin based chemotherapy, not just 5FU.
If there's any other question, otherwise we can just invite Dr. Naila. Thank you, Dr. Najib. Thank you. Dr. Naila, please just. Okay. Dr. Naila, she has a wonderful talk about these biomarkers and MSI and, about the chromosomal thing. Dr. Naila, first of all, I would like the crowd, all the seniors and juniors sitting here, any query, any comments you want to make, even a senior person. Any questions from Dr. Naila? Please provide the mic.
Thank you, madam. It was really a nice presentation. I just wanted to know that sometimes, investigations, they came like CT scan and MRI, and the tumor, accessibility is not possible. And sometimes when you open it up, the tumor is not resectable, and lymphovascular invasion is there in all these cases. So although it is being decided that tumor board will be there and it's a teamwork, so sometimes if these facilities are not available, so at that moment, what do you think about the tumor markers should be done? Or as Dr. Najib has already told, that if you are confused about the CT scan, then one should go for a PET scan, and about molecular tumor markers at that level, if you are confused.
Certainly the recommendations are that you do go ahead with the tumor markers, but basic histology is extremely important, and all these more fancier tests just supplement the basic histological information. So without that, I think we would really be groping in the dark if we go ahead and manage the patient. I realize the limitations that we have in this part of the world, but then after all, our role is to provide the most optimum care to the patient. So I think without histology and without these more sophisticated tests, one would not really be doing full justice to the patient.
Thank you.
Naila,
there are several exposures in the molecular pathway, like inhibition of cyclooxygenase 2 by using the non-steroidal anti-inflammatory drugs, or meat plus smoking, right? They are the carrier of the blood-borne carcinogens, which are the basically culprit to develop the colon cancers. On other hand, the book says that aspirin reduces the risk of colon cancer. What you will say in this?
Actually, I think as someone earlier said, one of the esteemed member in the group, that what we're really looking at is disease profile of Western population. And we have, in all these years, not been able to fully look at our own disease patterns and profile. And certainly these are culprits, and carcinogenesis is a very, very complex subject, and therefore we really are grouping with treatment protocols, and there is changes all the time. So I think our step, we as physicians or clinicians or pathologists should actually be really determining what is our disease pattern. Like we have a lot of high-grade signet-ridden tumors in younger population. No one has really, I know there are some scattered studies even from our institution, but we've never really looked at a large group or profile as to how really these tumors emerge, what are the family characteristics, are they syndromic, are there certain areas which they are more particular to. So I don't have a good answer to your question, and a very good question, because I think we just look at things in isolation.
Can you give the message from this stage? The vegetables are very good, producing the antioxidant and folate. These are the curable for colon cancer if we take the habits of vegetables and green salads. So I want to take this message from your side to the audience.
I think I will just essentially just repeat, because there are many other things which act as antioxidants. And but even despite the fact that we are a high meat eating country, I think we still have a lower risk of CRC as you compare it to the Western population. So there is something that is protecting us.
I'm not agree with you, because since 25 years I am doing the practice in the Civil Hospital Karachi. I am receiving the patient in a younger age, no symptoms, no PR history, no bleeding history. 18 years, 20 years, 25 years.
That's true. That's true. I think that's more genetic or syndromic somehow. It's not really dietary related, and we've not been able to fully understand that. Yeah, I fully agree with you. That's very correct. We see it all the time. And it's very disheartening when you look at a biopsy and you see it studded with signet ring, which we know. Probably, yes. I think so.
Dr. Naila, we talk a lot about, and we have so many studies on this, polyp into carcinoma sequence, which this P53 and, these KRAS and all these are involved. So what do you think, normally when the surgeons and the endoscopists, when they remove the polyp, they send it to you, and histopathology, you mention about everything, about histology, but obviously not in every case we send these markers. So do you, first of all, and the other thing is, where else is available all these two, apart from your own institutions? Are they freely available? These these MSI and the, you mentioned about the KRAS and T53. I know in your institution it's available.
Okay, let me just answer your first half first. Yeah. The first thing is that then we do, in the routine histology of polyps, it is recommended to point out when there is presence of high-grade dysplasia, which is a morphological finding. It is not currently recommended to do P53, which is an easily available immunostain across Pakistan in many leading laboratories, or any of the genes. That's not recommended. So it is not done. It is not even done in the Western countries. So that's one thing. We know there is obviously they are working behind, and that's what this leads to, this low-grade to high-grade dysplasia. And then as far as MSI or microsatellite instability testing is concerned, it is available in all leading laboratories of Islamabad, which would be Shifa, or Shaukat Khanam in Lahore, or Shaukat Khanam would do it otherwise also if you send the sample. And Chughtai Institute of Pathology, of course our own here, and I think there are other laboratories also in Karachi. So MSI is very readily available, it is not expensive, it is an immunohistochemically done test, so it is just like any cytokeratin that we do, a keratin marker, and that can easily be done. And it is reported as either intact or lost, and when it is lost, that means that there is presence of microsatellite instability. The other ones that you're talking about are available, KRAS, etc. You can do them as a single test, and I know once upon a time they were being sent to Singapore, even from our institution. Now that you have next gene sequencing available in Pakistan, I know there are, it is available at our center. For the colonic markers we do KRAS, NRAS, BRAF, EGFR, and TP53. It's expensive. It's to start with, it was expensive. It was about 65,000 rupees, and now because of the dollar-rupee disparity, it is now gone to about 86,000 rupees. I do understand it is expensive. And there are other centers that are coming up in Lahore. I know Chughtai Lab is going to be starting it very soon, if they've not already started. Same goes for Shaukat Khanam. And I think there are, I'm not too sure, I know NGS is available at NIBD, but I'm not sure if they're actually doing this particular panel or not. So this is how these things are available.
Thank you, very good information, and interesting to note that these are available, but at the same time cost effective matter यहाँ आ जाता है. So I would maybe ask oncologist Dr. Nadeem Abbasi, what do you think? Is it going to affect Dr. Nadeem?
Yeah, I think
cost effective.
Professor,
will it be a cost effective,
Professor Naila has very well covered the scientific side of it.
Yeah.
Now comes the ground reality. Yes. I personally think that if we strengthen our MDTs and our intra-departmental, interdisciplinary peer review, we can avoid many, these cost. I'm not targeting this particular issue, but I think wherever the cost comes, like I'm a radiation oncologist, I always try actually to get away with one single fraction, because I'm very much aware of the cost. So I think the answer is not picking up one test price. Maybe this is very important for life saving of that poor patient.
For
then
example,
we can get the donations.
I'm just repeating my question that Dr. Naila just said, like in a polyp sequence, if she's saying that if there is a high dysplasia, it's recommended.
Yes.
Now the cost effective, as we just mentioned, it is not cost effective, like 60,000.
But the peer review can decide that. We have experts available.
Will that affect the prognosis?
Hopefully not.
We are very
Hopefully
unfortunate.
not.
From scientific point of view, we have to do each and everything. On ground realities, we are unable to do so. So from the academic point of view, we have to do it for the life saving of the patient. We are a physician and we have to treat the patient. We are very unfortunate in this era.
Amjad Siraj Memon very well commented. You have a rural patient who got, compliance is sitting there.
Of the health department.
So what I was thinking that let the experts decide. So for me, surveillance is ideal, and that's what written in the books, and I'm presenting it in international forums. But when it comes to my patient coming from a very remote area from Sindh, they got very little money. So breast conservation may not be applicable for that lady, because they got very little money for surgery, not for neoadjuvant chemotherapy. So we can let's go and do the mastectomy. So that is, I think, that's why we are called experts, that we have to serve our own country and then cost effective. But if the experts say this expensive test or radiation or tomotherapy or whatever is required, then it is required.
Thank you, Dr. Nadeem. Professor Faraj Jalil has some comment to make. Professor Faraj Jalil.
It has been very well highlighted that
on karle.
It has been very well highlighted that tumor biology assessment is extremely necessary to decide upon the treatment, prognosis, and prediction of the disease and its recurrence. So we have all felt that the tumor biology in our country is a little different from the West. So I think the answers to all these can be if we do a lot of local research on our own tumor biology, but that of course ye jo bhi, that needs a lot of labs to do these tests and a lot of resources as well. So I think the local research can help us in determining our own spectrum of the disease, and then we can tailor the treatment and the algorithm for the treatment of these diseases.
Yeah, I agree with you. Obviously, that would be the right direction to take. But I think to the comments that were made earlier, I think we need to have an optimum treatment for the patient. Everything is expensive. Surgery is expensive, radiology is expensive, laboratory testing is expensive, and treatment is even far more expensive. So, you need to know, because if you treat a patient, say, with 5-FU or some of the other more fancier drugs, and then not knowing that this patient has KRAS or BRAF, mutations, and they are not going to respond to treatment, they're going to have severe side effects. So we need to be cognizant of that fact, that are we doing more harm, and just by saving a smaller amount as compared to the treatment cost. The treatment cost can be as high, according to the US literature, $70,000 US. So in that, a $200 test doesn't mean really much. So
I have a question, please, ma'am.
Yes.
Sorry,
Yes.
here.
Last question, because we have running short.
Ma'am, Dr. Najib has also mentioned that GloboCan is not really a true representative of prevalence of colorectal cancer here. And you've mentioned a registry where multiple institutes are adding data to. Can you please elaborate, and can we access that online for reporting?
Yes, that data is now available. It's called the cancer, I think it's called the Karachi, now even also the Karachi Cancer Registry. And I know that there are a number of institutions like Jinnah, AKU, maybe, I am not sure of Dow, that are contributing to it, Indus, Ziauddin, and there are other hospitals across, and this is being regulated by the NIH. And I think they've published, yes, NIH Islamabad, NIH in Islamabad, and they may have regular presentations, etc. One of my colleagues is actually actively involved in it. I am not directly involved, but I'm aware of it.
Thank you very much. Thank you, Dr. Naila. Now I would request Dr. Sarish Abrar to please come on the stage. And questions
Only
are
one
open.
question from the audience, please, because we have a very short time. Running already very short. Only one question from audience, otherwise I have to comment. Dr. Sarish?
Dr. Sarish,
one question came from.
Thank you for your elaborate talk. It's more a request than a question. Rather than having an institutional site-specific tumor board for this topic, I would request you to take the lead and have a citywide multidisciplinary group of experts who could actually lead the management of watch and wait for complete responders, as well as
I strongly
registry
second it, actually. I think it is a high time that we announce it today in this meeting. Thank you for bringing this forward.
Thank you, Dr. Raza.
Any more, please?
One more question, if there anybody. Anybody has?
Dr. Sarish, you are chairing. Dr. Sarish?
कुछ कह रहे हैं? Okay. कुछ कह रहे हैं? माइक दे दें प्लीज डॉक्टर साहब को, डॉक्टर नजीब को माइक दे दें.
Means in organ preservation, if you just do chemoradiation and leave the patient on watchful waiting, how easy is to do surgery later on after radiation?
I think a surgeon can answer this question.
This is for the surgeons.
Yeah.
Because after fibrosis in pelvis, it's very difficult to take out rectum. So my question is to surgeons.
Ji, first of all, I would leave anybody. Dr. Tavish, you want to comment on this? Dr. Najib, the question is please repeat kar dein. After chemoradiation?
After chemoradiation, if the interval is prolonged, means the patient is put on watchful waiting, and the patient has recurrence, how easy to do this surgery? Okay. Because after fibrosis in the pelvis.
I'll answer that. Dr. Tavish or koi surgeon dena cha raha hai iska answer?
I would only quote Professor Amjad Cheema, who answered this question a few years ago. He's not in the audience, so I will just take this opportunity to quote him, that the response to radiation and the fibrosis, it varies over time. Like we know that over the first 12 weeks or so, we don't have a lot of fibrosis and we just encounter edema, and then fibrosis starts setting in. And it then starts to dwindle for another maybe a couple of years. So there is a time period that comes that the fibrosis is reduced. However, whenever we identify the tumor, encountering whatever difficulties we get, this is an advantage that the patient gets by preservation of the sphincter, and we have to give that advantage to a larger number of patients. And then of those 25 or 50% in different series, whoever recur, we can go ahead and take that out with their own risks, yes. Majority of time it will be, not be possible to preserve the sphincter in these situations. So we are less concerned about the function or LAR syndrome because of the fibrosis.
Dr. Tabish, you want to say something?
Well, Raza has elaborated it well. I will only add that, as he was saying, the timing is important, and if we do within the 12 weeks period, then the edema actually is helpful. If we encounter late recurrence and we need to still excise, if we're not going for sphincter preservation, the other approach is translevator resection, as we do in some cases, and not going into that area at all and doing a wide resection, a cylindrical resection, and that should be easy to do and will achieve the oncological principle.
Yeah. Dr. Sarish, I must congratulate you that you are chairing rectal study internationally. Can you share your experience with us about that study?
Thank you, Dr. Noor, for this wonderful question. Well, before sharing my experience, I want to share my motivation for starting this study group. So during our residency, many of the residency, the oncology patients being mismanaged. Exactly during my residency, I see many patients who are being mismanaged. But when I started my practice as a consultant, it was my third or fourth clinic, I saw a patient in the clinic. She was a 60+ female, and she had a middle rectal cancer tumor, and one of the renowned surgeon advised upfront APR to that patient. And I shared that case with Dr. Abbasi. So it was Dr. Abbasi's brainchild to start this forum where we can talk about the unnecessary APRs of the patient. So under this forum, so far we have conducted multiple talks by the international speakers who talked about the sphincter preservation, and the whole sole purpose of this study group is to share the knowledge and fill the knowledge gap of our senior and the junior colleagues. And we also have a repository where we are collecting all the contemporary literature regarding the rectal cancer management.
I must congratulate you in this age. You are chairing internationally study. Thank you. Dr. Suresh. Thank you, madam.
Thank you.
Thank you.
Thank you, Dr. Sarish. Ji, Dr. Suresh, please aaiye.
Any question from Dr. Suresh?
So, Dr. Najib, was that you're satisfied with the answer? Obviously, that is difficulty because at the time period you leave, and obviously there is a chance of, and God forbid, injury to, because to any structure, because you don't get the proper planes. But I think time you need to give 6 weeks has been. Ji, Dr. Suresh, any questions from Dr. Suresh? He mentioned about he gave a talk on WHO new guidelines on neuroendocrine tumors. Any question from the crowd, from the respected?
सारे क्वेश्चनों के जवाब सर ने दे दिए, मैडम ने दे दिए।
अच्छा, नहीं कोई any comments कोई देना चाह रहा हो कोई भी?
Keratocarcinoma, sebaceous glands, you have mentioned MSL1 and MSH2 and this. Do you think there is necessary to do in these things?
Yes, sir, because they are the already madam mentioned that the patient have two groups basically. We divided the sporadical cases or they are syndromic. If the patient is syndromic, then we can evaluate. If a female patient have syndromic, then we should go for the endometrial biopsy to rule out the endometrial carcinoma.
What I saw in the histopathology is more dominant in the males. It is true?
Yes. These are the males. So we can offer the the offspring of their child.
Is it
Yes.
easily available in Pakistan?
Yes, these are available.
Available in the Pakistan.
Yes.
And you talk about the PDL1.
Yes.
It is the era of PDL1 nowadays.
Yes.
Because our biology depends upon the PDL1.
Yes, these are the
when
programs.
you have these tests, you have to do the immunotherapies on these type of the days.
Yes, sir.
Right?
So these are the program ligand proteins. These are now recommended to the MSI patients. No?
Any other comments before we conclude? I just want to, first of all, thank everybody. Thank you, Dr. Suresh. Okay, thank you. So, once again, I want to thank all our distinguished and respected presenters. Just want to make one more comment. It was basically more relevant to Dr. Sarish's presentation and in view of that, but I mean, I'm talking about general of colorectal. As you mentioned about the preservation of the organ, early diagnosis, early excision. I think one comment what I want to make here is early diagnosis and screening. I think that more needs to be, followed because in our cases, many patients come with bleeding PR, and yesterday also, this was discussed yesterday, that many patients have hemorrhoid bleeding, and many times the diagnosis is delayed. So I think early diagnosis is the key, and screening, of course. So
thank you very much, all of you.
I thank all of them, all of our speakers.
Thank you, Dr. Sidra, for conducting this session. And this session was full of profound knowledge.
Now I would like to call upon Dr. S.M. Abbas for distribution of certificates among the panelists, speakers and moderators. Dr. S.M. Abbas is in Head of Department of Surgery and Allied Departments at Hashmani Group of Hospitals. First, Professor Fuad Ali Musa, sir, please come forward to receive your certificate. Professor Farhad Jalil. Dr. Noor Mohammad Sumro, sir, please accept your certificate. Dr. Nadeem Abbasi.
Now the speakers, Dr. Najib, sir, please move forward and receive your certificate. Dr. Naila Kiani, ma'am, please come on the stage and receive your certificate. Dr. Sahrish Abrar, ma'am, please. Dr. Suresh Kumar, sir, please move forward.
Dr. Sidra Masoom, the moderator of this session, please come forward and receive your certificate. Thank you, Dr. S.M. Abbas.